Yes, sir.
Okay.
Yes, sir.
Yeah. So what I did today, because this is the first lecture, I thought that we'll do some basic stuff. And these are the things what I tell people that, look, listen to this, try to remember things, and then if it stays somewhere in your brain, when time comes, you can look up the book and review it. And it's necessary to review it from time to time. This is the heart. It's actually says the chest has been open for most probably some kind of cardiac surgery, and you can see that this is the right atrial appendage, and most of this is the LAD where it should be. This is the fat that's going on. This is the right ventricle. This is the left ventricle. This is the aorta, and this is the pulmonary artery going. That's the concept. It is important to remember the anatomy from time to time, because we look at the chest. We never, a lot of times we don't think where each chamber is. So if this is made into a okay, so this is the diagram of the same heart. So you can see that this is the left atrial descending artery going here. Right ventricle is up to here. It overlaps in the front, unless it is rotated. So aorta, right coronary artery, left main, left anterior descending coronary artery, and right coronary, left circumflex. And this is the right atrium. So if we open the heart, this is a diagrammatic representation. So we have this sinus node, which is at the junction of right atrium and superior vena cava, AV node, and then bundle branches. And as you can see, there has been drawn some connections between these, and these are called sino-nodal connections. But these connections are not histologically or electrophysiologically proven. This is, we think that there are some preferential conductions, but we have never been able to prove it by any means. And so I'm going to skip this one. So if you open up the heart from the right side, you can see that the sinus node is located at the junction of superior vena cava, right atrium. It is not a small dot the way we normally draw it. It is a long structure. It's about 1 inch long. That means 2.5 centimeter long structure. And then we have the AV node, and this is the right bundle, which comes down, goes through the moderator band to the lateral wall of the right ventricle. And that's why when we do catheterization, sometimes we can bump into this and cause the right bundle. This is fairly superficial on this side. And on the left side, left bundle is a little bigger. It's a wider structure. It's flat, and then it goes into left anterior fascicle, left posterior fascicle, and then it distributes. And you can see it is actually subendocardial, all these structures. And these are the structures that conduct the electricity very fast through the both ventricles, and within a period of about 80 milliseconds, just the duration of the QRS complex. And if this conduction system is disrupted, the QRS becomes wide. So this is, you can see that on a specimen, you can see this faint streaks. This is where the left bundle is, and it has been drawn here. So histologically, you can find it with dissection. The AV node, this is the right atrium, and little difficult to understand, but this is where the inferior vena cava is. This is coronary sinus. This is tricuspid valve. This is the superior vena cava. This is right atrial appendage, and this is fossa ovalis. And the AV node is somewhere here. And why it's important for us, especially as people who do electrophysiology study, that we use the coronary sinus as a landmark, and then we think that the AV node is somewhere here. And this is how it's, again, if we look at the picture again, that this is the coronary sinus, this is tendon of Treador, and this is where the AV node is. Even though AV node has been drawn as a complex structure, it is not. It is actually, there are branches. It's like a tree root. And this is where the area of slow pathway is. And this is the AV node fast pathway. And this is important because that's how we get AV node reentrant tachycardia. And this is the tricuspid valve. If any of the audience have problem, please stop me. I want to go slow because unless you look at it carefully, it's difficult to get confused with the orientation. This is the inferior vena cava. So again, coronary sinus, tricuspid valve, this trigon on the top is the AV node, and this goes to the bundle, his bundle, and then bundle branches. So as you can see, it goes upward a little bit and then goes down. And as it goes upward, we are closer to the aortic valve. And that's why when people go for aortic valve surgery, sometimes this conduction system can be damaged and patient can develop heart block. Same thing happens with TAVR procedure, that we get about 10 to 14% incidence of heart block because this conduction system is passing close to the vertebra, and the pressure and the mechanical things. So also patients with aortic stenosis get fibrosis, and this conduction system can be damaged more often in patients with aortic stenosis than other valvular disease. This is again just anatomy. If you look from the bottom, this is the left ventricle, this is the mitral valve, tricuspid valve, and as you can see that mitral valve, and then there is this papillary muscle and tendons which is holding the valve. These muscles are very important anatomically, functional wise, also electrically. Sometimes they can produce arrhythmia. And this is a longitudinal section of the left ventricle. As you can see, this is the papillary muscle, and then this trabeculae connecting to the valves and holding it and preventing it from prolapsing into the left atrium. And this is the left atrium. This is one of the coronary arteries and probably the coronary sinus. Again, another section, left ventricle and the right ventricle. Right ventricle, as you can see, is much thinner structure compared to the left ventricle. And so when we put catheters and stuff in, there is more likely to perforate than the left ventricle itself. So if we look at the junction, it's interesting. This is important for electrification. This is the left side, left atrium, and the left ventricle junction. It comes down and it connects to the ventricle, and it's a straight line. So if we want to do any kind of ablation, and there is an accessory pathway here, I can put a catheter here and heat up, and I can damage this accessory pathway and ablate it. But right side, if you look at the right side, it's kind of folded like this. So that's why if there's an accessory pathway and I ablate here, I'm actually far away. That's why the right-sided accessory pathways are difficult to ablate and requires more energy compared to the left side because of this folding of this junction. I don't know why this folding happens, but some kind of embryological. You can see this folding. This is the right atrium, and the right ventricle is connecting, and it's folded here and producing a thicker area of tissue. So the cells itself, that myocardial cells are different from muscle cells in a way that muscle cells are individual muscle cells, and they are stimulated by the nerves. Myocardium is syncytium. That means there is a cell here, but it is also connected to another cell. And that's how they communicate with each other. And if you look at this, it's a longitudinal section. It runs longitudinally. And this is where the junction is the intercalated disc. And this electron microscopic view. Why is this important? I mean, just remember this. Look at these different structures. This is the actin filament. Actin filament, actin. This is intercalated disc, and on this side actin. And then there are connections with different kind of proteins. And we have now identified there can be abnormality of these proteins, and which can cause cardiac arrhythmia, cardiomyopathy. And like this one, if we look at the dilated cardiomyopathy, alpha T catenin, and where is the alpha T catenin? This is the alpha T catenin. This is connecting the actin filament to this one, and this can be defective. And then there is another one, let's say plakoglobin. This one is related to arrhythmogenic right ventricular dysplasia. And so this is the plakoglobin. This is amazing that how far medicine has progressed in understanding this cellular mechanism of disease. And these are important that today we don't have any medicine, but maybe tomorrow or maybe 50 years from now, we'll be able to fix these things at a cellular level. And we have a lot of medicine that we actually have been developed after finding this concept that, look, there is a problem here. Is there something we can find to fix it? Before, we just thought of the heart itself as a big structure. So please read up about these things. These are important proteins, important histological findings. And then I'm going to show you this actin filament and myosin. You all know this structure. I always loved it as an anatomy class. And this is how it contracts, that the myosin connects with the actin filament and then bends. And when it bends, so it is connected like this. If it connects and bends it, then it pulls the muscle. And that's how the myocardium contracts. It's an amazing mechanism. And you imagine that this is a small structure, how much force it is generating. And that force you can only feel if you ever pull a pacemaker lead out, and you can realize how strong the heart muscle is when it contracts. Now, there are different kinds of myosin chains, like beta myosin, heavy chain, myosin, light chain, and there can be defect of these also, which is causing cardiomyopathy, which is hypertrophic cardiomyopathy. And now there is medicine that came out that is working in one of these sites. And so what happens with hypertrophic cardiomyopathy is that these cells are longitudinally oriented. Because these are defective in myosin, the heart cannot contract as good. And as a result, it hypertrophies. But when it hypertrophies in a disorganized way, and it becomes a substrate for cardiac arrhythmia. So electrically, if we look at electrical system, you know the action potential. I'm going to focus on the sinus node. Look at this sinus node action. It's kind of sinusoidal. There is no sharp point. But if you look at the ventricular action potential, you can see it is sharp. And then it comes down to baseline. And once it comes down to baseline, it's straight. What the difference is that ventricular action potential, you have to trigger it with some kind of stimulation. And once you stimulate it, you develop the action. If there is no stimulation, there will be no action potential. That means this ventricular tissue will not contract without a stimulation from somewhere. On the other hand, the sinus node, and also to some extent AV node, has the potential to generate its own impulse. So it keeps going, and then once the action potential changes, it again changes in electrical activity, and then it goes and beats again. So this is the fundamental difference between these two tissues that sinus node, AV node can generate. And some of the tissue in the Purkinje can also generate its own impulse, but not as good as the sinus node and the AV node. So this is what it is that cells have more sodium outside, potassium inside. And how does it do it? There is a ATP-dependent sodium pump, which pumps sodium out and potassium comes in. So 3 sodium goes out, 2 potassium comes in exchange. And there is also another kind of exchanger, which is called sodium calcium exchanger. That means sodium comes in, calcium goes out, or the other way around. So this part is these two ions are controlling it. And what are these pores? These, if you look at this, 3 sodium again, and then potassium and sodium and calcium, calcium moves against gradient, and the driving force is the sodium going this way. So this slide is important. If you look at this slide, that this is the action potential of the sinus node. There is the action potential. It comes back to depolarization, repolarized state, and then it continues going up until it reaches the threshold potential to do it. And this is done by inward current, what is called funny current. And that funny current is potassium dependent. And there is a new drug called ivabradine. It is available in Bangladesh, and it works here. So people always ask me, can I use ivabradine to slow heart rate in AFib? You cannot, because ivabradine works in this current. It has no action on slowing down the AV node. So ivabradine should not be used for patients with other kind of tachycardia. It is exclusively designed to work for sinus cardia. Ivabradine is not going to work for supraventricular tachycardia because that's a re-entry mechanism. So it only works on the funny current. It's a wonderful medicine for patients with inappropriate sinus tachycardia or patients with cardiomyopathy whose heart rate remains 80, 90, or 100 despite maximum beta blocker. Let's say there is a patient whose heart rate is 100, blood pressure is 100 systolic, and you cannot go up on the beta blocker. You give ivabradine, and patient has cardiomyopathy, you give ivabradine to that patient, the heart rate will come down, and a lot of these patients are going to feel better. But ivabradine should only be used after we have maximized the maximum tolerable dose of beta blocker. But it's a great drug. Look at the action potential of the ventricular muscle. You put a stimulation in, sodium goes in, and then potassium keeps coming out and balances out, and it gets it's depolarized and repolarized state. And there are phases: phase 0, phase 1, phase 2, phase 3, phase 4. So this is a cell membrane. You remember from the anatomy class, I don't know if you remember it, but we did. It's a bilipid layer. This is a cell membrane, and there are holes in it guarded by gates. Like here, the gate is closed and the gate can be opened. It's a unique mechanism to think about these structures at a cellular level. Is amazing that how these cells are working. And then what happens? Interesting that look at this gate. This gate is closed. This is the bilipid layer. And then for some stimulation, gate opens up and electrolyte comes in. And there is a temporary gate which deactivates until finally closed, a resting state. And from the resting state, it will only open when there is a stimulation. So it will close up, open up, and then close with the temporary gate and then become a resting state. That's how this keeps going on. Now, look at this interesting slide that there is a sodium channel. This is open. And where the lidocaine is working is over here. So there is a specific location where the lidocaine works. Lidocaine works on sodium channel. Now, look at this calcium channel. Calcium channel, there are different calcium. Diltiazem works in this location. Nifedipine works in this, and verapamil works in this location. And it may explain their difference in action. That if you know that nifedipine is mainly an antihypertensive, diltiazem can actually cause blood pressure control, also cause heart rhythm problem control. Verapamil is stronger heart rhythm problem control medication plus an antihypertensive. So it's the location. It's a basic science, and I'm sure some of you will work at a cellular level at one time in your life, or maybe build up as a career, because Bangladesh is reaching a phase that we will need basic scientist physicians, and you will probably study these things. So what is the mechanism of cardiac arrhythmia? I'm going to go to a different slide. I'm going to stop here. And if there is any question, I'll go answer. Any question?
Sir, it might sound a bit stupid, but my question is, these calcium channels, sodium channels, and these channels are present in all cells, not only in cardiac cells. So
yes,
when we block the sodium channel or calcium channel blocker, the impact should be everywhere, in every cell. So
yes.
how does it specify? Is there any other mechanism?
Yep. So the question is, it's a very interesting question, that if you look at verapamil, it causes constipation. So it's not that we have got rid of, like if you take amlodipine, it doesn't cause constipation. Diltiazem doesn't. So they have, I think these drugs have been designed to be specific for specific receptors. Like as I showed you that even the calcium channel blockers, they don't work in the same location. So yes, there is some, I mean, that's why we develop side effects on the medicines. As I mentioned, the side effect of verapamil is constipation because it affects the gut muscle.
Sir?
Yeah.
So Rafique bhai,
Yeah.
may I add something on this issue?
Sure, please do.
Because the is going back to Guyton's physiology book, the depolarization and depolarization properties for the cardiac cells are different from the intestinal. So, and also even for the SN node and AV node versus the myocardial fibril is not the same. So therefore the effect also for the drug when we use in therapeutic dose is not going to be the same on the SN node, where the SN node is the target for the drug, or AV node versus myocardial cell compared to other cells. So it has huge sort of implications in a way that is a pharmacodynamic effect, the individual cell properties, and also the pharmacokinetics of the drug. If we need to look at the overall outcome from a drug administration.
Thank you. So think about a drug like lidocaine. Lidocaine stabilizes the myocardial membrane, but it also works on the brain. Same as magnesium we use for torsade, but it is used for eclampsia because these are membrane stabilizers. So, but they're a little bit non-specific. Secondly, depending on the dose of the drug, how much are you using? Is this big enough to affect the other cells in the body? Thank you. Any other question?
Sir, there is a very popular term, junctional. Actually, what does it mean, sir, from your anatomy?
Oh,
Junctional.
Junctional means area happening from AV node area. So any tachycardia that is happening in the AV node area, but if you look at true junctional rhythm from electrophysiologic standpoint, should be something that's an automatic tachycardia. And that's more common in children than adults. And if it happens mainly after cardiac surgery in children, their AV node becomes the dominant pacemaker. It overrides the sinus, and they can develop junctional tachycardia. On the other hand, people use it also as a blanket term that if we cannot see a P wave, people use, oh, I cannot see a P wave, it's a junctional rhythm. So it's a broad term that is used, but to be specific, it has to be a junctional tachycardia, but that we can only define by electrophysiology study.